So, picture this. A guy, let's call him David, late 40s, life feels, well, normal. Maybe he's a bit more tired lately, thinks he could probably eat healthier, maybe join a gym. Sounds familiar.
Yeah, I'm very familiar.
But here's the thing. Beneath the surface, totally, silently, invisibly, his blood pressure is starting to nudge upwards just a little bit.
Right. No big alarms going off.
No alarms at all. Year after year, no obvious signs, just this slow, steady creep that he's completely unaware of. And this kind of silent step-by-step thing, it's happening right now in countless people.
And if, nothing changes in David's life, that quiet increase, it isn't harmless. It starts to put a strain on his arteries, right? His heart has to work harder.
Yeah.
Maybe even his kidneys start feeling the pressure. Later on, he might get persistent headaches, occasional dizziness, perhaps even some chest discomfort, signals that are harder to ignore.
Definitely harder.
That's the really insidious nature of how many diseases develop. They sneak up on you.
Exactly. And if it still goes unaddressed, this whole chain of events could lead to something major. A heart attack, a stroke, kidney failure.
Yeah, the big ones.
That entire sequence, from those first undetectable changes all the way to those potentially life-altering outcomes, if no intervention occurs. That's the journey we're really going to explore today.
That journey, right? That progression from being healthy through the different stages of illness to a potential endpoint.
Yeah.
That's what we call the natural history of disease.
Natural history of disease.
Think of it like the inherent unfolding of an illness if you just let it run its course, completely unchecked, without any medical treatment, no public health efforts stepping in, and understanding the silent step-by-step progression. Yeah. That's absolutely the key. It's how we unlock effective prevention, effective treatment strategies. It's really about knowing the enemy before it fully emerges.
Okay, let's unpack this natural history idea a bit more. It almost sounds like we're just watching something bad happen without doing anything. Why is understanding this observation phase so fundamental? It seems a bit passive.
Well, it might seem passive, but understanding this natural progression is, honestly, foundational. It's the bedrock. Everything else is built on top of it.
Everything.
Pretty much all effective health strategies, whether it's a doctor figuring out the best way to treat an individual patient or, global health organizations designing huge campaigns to protect entire populations.
Yeah.
It all comes back to understanding this natural course.
Right.
So our mission today in this deep dive is to really dig into why this concept is so crucial and how it informs, well, practically everything we do to safeguard and improve health.
Okay, so let's get specific then. What exactly is the natural history of disease? Like the formal definition.
Right. Formally, it's the progression of a disease process in an individual over time, in the absence of intervention. That last part is key.
No treatment, no prevention.
Exactly. It's like the unedited story of an illness.
Yeah.
And knowing this inherent storyline, that's what allows us to pinpoint the critical moments where we can step in, where we can make a difference.
How so?
Well, to prevent the story from starting in the first place, maybe catch it in its really early chapters, treat it effectively in the middle, or even just minimize the impact as it progresses towards the end.
Got it. And this storyline, this progression, it isn't just one long event, right? You mentioned stages.
Precisely. It's not monolithic. While the details vary a lot from one disease to another, we can generally recognize 4 key stages.
Okay, let's break those down. Lay out these stages for us.
Okay, first up is the stage of susceptibility. This is the period before the disease even begins. The person is technically healthy, but they have certain factors that make them more likely to get the disease down the line.
These are the risk factors we hear about all the time.
Exactly. Risk factors. And they can be really broad.
Like what? Give us some concrete examples.
Sure. It could be genetic predispositions, maybe inheriting genes that increase your likelihood of certain cancers, for instance.
Okay.
Environmental exposures play a big role. Living in an area with poor air quality, maybe. Behavioral factors are huge. Smoking, diet, how much exercise you get.
Right, the lifestyle stuff.
Yep. And we also have to think about the social determinants of health. Things like your socioeconomic status, your access to good health care, education level. These can seriously impact your risk.
That makes sense.
The crucial thing here in this susceptibility stage is that the person is at risk, but the actual disease process hasn't kicked off yet.
Okay, so at risk but not yet affected. Clear. What's stage 2? What happens next?
Next is the stage of subclinical disease. This is where the disease process actually begins. Maybe there's an exposure, like to a virus, or perhaps those risk factors we just talked about have kind of coalesced and started causing biological changes in the body.
But subclinical means?
It means no recognizable signs or symptoms. That's the key. The person feels fine. Standard medical tests might not pick anything up yet. It's happening under the radar.
So like David's blood pressure's slowly creeping up for years. He felt fine, but the change was happening.
Exactly like that. Perfect example. For infectious diseases, we often call this the incubation period, right? The time between getting exposed and actually feeling sick. But for chronic diseases like hypertension or atherosclerosis, where arteries slowly narrow, this subclinical phase can be really long. We're talking months, years, even decades.
Decades? Wow.
Yeah, the disease is silently taking hold.
Yeah.
Think about the very first few cancerous cells starting to grow, or that initial plaque buildup in the arteries. It's happening, but you don't know it.
That is a bit unsettling, isn't it? The idea that something could be progressing for so long without any warning signs. So what finally tips the scales? What makes it apparent?
That leads us right into the stage of clinical disease. This is when the disease finally manifests with recognizable signs and symptoms. The person starts to feel unwell, they notice changes in their body.
And this is usually when they seek help.
Often, yes. It prompts them to go see a doctor, which eventually leads to a diagnosis. The hidden phase is over. It's now overt.
And the way it shows up, the symptoms, that can vary a lot too.
Absolutely. Symptoms can range from really mild, easily brushed off, maybe slight fatigue, a minor cough, to severe and debilitating, like the intense pain of a heart attack.
Right.
The defining factor, though, is that the disease is now clinically apparent. You can see it, measure it, diagnose it based on symptoms.
Okay, so we've got susceptibility being at risk. Subclinical disease starts but no symptoms. Clinical symptoms appear, diagnosis happens. What's the final chapter in this story of a disease?
The final stage is the stage of disability or recovery. This basically represents the ultimate outcome of the disease process, again, without intervention.
And there are different possibilities here.
Yes, several paths. One is recovery. The person returns to their previous state of health, maybe completely, or maybe with some lasting effects. This is pretty typical for many acute infectious diseases like the common cold or the flu for most people.
Okay, recover is one outcome. What are the others? They sound less positive.
Generally, yes. Another outcome is chronic illness. The disease persists long-term, often needing ongoing management to control symptoms and prevent things from getting worse. Think diabetes, arthritis.
Things you live with.
Exactly. Then there's disability. The disease leads to some kind of impairment or limitation in function. It could be temporary or it could be permanent.
Like after stroke, maybe?
Precisely. And sadly, for some diseases, or in some cases, the final outcome is death.
So it's quite a range of possibilities once you hit that clinical stage.
A very significant range. And again, understanding these stages, their typical timelines for different diseases, is just absolutely critical for figuring out the best points for us to intervene.
You mentioned flu and diabetes earlier as examples. Maybe walking through those again with these stages in mind would help cement the idea. Let's start with influenza, the flu.
Sure, good idea. So for the flu, the stage of susceptibility might be, well, being exposed to the virus during flu season, especially if you haven't had your flu shot. You're vulnerable.
Okay.
Then the subclinical stage, that's the incubation period, usually lasts about 1 to 4 days. The virus is replicating in your system, but you feel okay for now.
Right. Then you wake up feeling awful.
Exactly.
Yeah.
That's the clinical stage starting. Fever, cough, sore throat, muscle aches, the familiar misery.
Yep.
And for most healthy people, the usual outcome is recovery. Within a week, maybe 2, you're back on your feet.
Pretty straightforward. Now, contrast that with something chronic like type 2 diabetes. That feels like a much longer, more complex picture.
It really is. The stage of susceptibility for type 2 diabetes often involves a mix of things, maybe a genetic predisposition, a history of being overweight or obese, not getting much physical activity, often playing out over many years.
So the risk builds over time.
Right. Then comes the subclinical stage, and this can be very long. Insulin resistance starts developing, your body doesn't end up glucose as well, but no noticeable symptoms. Years can easily pass like this.
Silently progressing again.
Silently progressing. Eventually, the clinical stage might arrive with symptoms like being really thirsty all the time, needing to urinate frequently, unexplained fatigue. That often leads to the diagnosis.
And the outcomes.
Well, if it's not managed well, the outcome is typically chronic illness. It needs ongoing monitoring, treatment, and there's the risk of serious long-term complications, nerve damage, kidney disease, heart problems. which can definitely lead to disability.
Okay, yeah. Seeing those two side by side really highlights how differently these stages can play out. So the crucial question then, how does knowing all this, understanding this natural history, actually help us? You said it's foundational. How does it guide what we do?
It truly underpins, well, everything we do in health strategy, both public health and individual medicine. It's the blueprint. It guides how we approach preventing disease, detecting it early, managing it once it appears. Let's look at the three main levels of prevention.
Prevention. We hear that word all the time. How does this natural history concept connect directly to prevention?
Okay, so primary prevention. That's all about stopping the disease from ever happening. Job one, right?
Right. Stop it before it starts.
Exactly. And to do that well, you need a deep understanding of that first stage, the stage of susceptibility. You need to know who is at risk and what puts them at risk. If we know those risk factors, we can develop strategies to get rid of them, or at least reduce exposure.
Can you give some tangible examples? Where does understanding susceptibility lead to real-world primary prevention?
Oh, absolutely. Think about anti-smoking campaigns. Huge public health success story. They're a direct result of understanding that smoking is a primary risk factor for lung cancer, heart disease, loads of other things.
Something learned by observing the natural history in smokers versus non-smokers.
Precisely.
Yeah.
Or food fortification, adding folic acid to bread and cereals. That came from understanding that folic acid deficiency during pregnancy, a state of susceptibility, leads to neural tube defects in babies.
Right.
Vaccinations are a classic example. They work by preparing your immune system before you're exposed to the bug, basically making you non-susceptible.
Getting ahead of the game.
Exactly. Cleaning up water supplies to prevent cholera that tackles an environmental risk factor. Promoting healthy diets and exercise to reduce heart disease and diabetes risks all targeting factors in that susceptibility stage. All these efforts are grounded in knowing what initiates the disease process.
Okay, so primary prevention is about preventing the story from even starting. What about when the story has begun, but it's still in those early silent chapters, the subclinical stage?
Right, that's where secondary prevention comes in. The focus here is on early detection and prompt treatment. Ideally, catching the disease during that subclinical stage before symptoms appear, before it progresses too far.
So the goal is to stop it or slow it down early.
Exactly. Halt or slow the disease, prevent complications later on, and generally improve the person's long-term outcome.
And what kind of things fall under secondary prevention?
Screening programs are the classic examples. Mammograms for breast cancer, pap smears for cervical cancer, colonoscopies for colorectal cancer.
Why those tests specifically?
Because our understanding of the natural history of those cancers tells us they often develop from precancerous lesions over time. There's a window during the subclinical stage where we can detect these changes.
Oh, okay.
That knowledge informs who should be screened, when they should start, how often they need it. Same idea with regular blood pressure checks for early hypertension or blood sugar tests for prediabetes. These work because we know there's a detectable subclinical phase.
Trying to catch it while it's still quiet? Makes sense. Now, what if we miss that window? What if the disease progresses and someone actually starts having symptoms? The clinical stage.
Okay, now we're talking about tertiary prevention. This comes into play once a disease is established, it's in the clinical stage, or maybe it's already led to some level of disability.
And the goal here isn't stopping it anymore, right?
Not usually stopping it completely, no. The aim is more about minimizing the impact of the disease, limiting disability, preventing further complications, promoting rehabilitation. Basically improving the patient's quality of life and functional capacity as much as possible.
Okay. Examples of tertiary prevention.
Think about rehab programs after a stroke, physical therapy, speech therapy, helping people regain lost function.
Right.
For someone with diabetes, tertiary prevention is about tight blood sugar control, regular foot and eye exams to prevent complications like nerve damage or blindness, and educating them on self-management.
Managing the ongoing condition.
Exactly. Managing chronic pain, providing supportive care for people with dementia, fitting prosthetic limbs after an amputation. That all falls under tertiary prevention. These actions are guided by knowing the typical complications, the likely progression, and the potential for rehab based on the natural history of that specific condition.
It's like managing the story as it unfolds, trying to steer it away from the worst possible ending. You also mentioned public health interventions for infectious diseases. How vital is understanding the natural history there?
Oh, it's absolutely paramount, especially during an outbreak. For infectious diseases, understanding things like the incubation period, that silent subclinical phase.
How long it takes to get sick after exposure.
Right, and the period of communicability when someone can actually spread the disease to others, sometimes that overlaps with the subclinical phase, which is tricky.
Meaning people can spread it before they even know they're sick.
Exactly. Also, knowing the modes of transmission, how does it spread? Droplets, airborne, contaminated surfaces, and understanding the typical severity and outcomes. All of these are parts of the natural history that are critical for designing effective public health responses.
Can you walk us through an example? Maybe a new virus appears.
Sure. Imagine a novel respiratory virus emerges. Public health officials are scrambling. They urgently need to figure out its natural history. How long is the incubation period? That tells them how long people might need to quarantine if exposed.
Okay.
When are people infectious? Can they spread it before showing symptoms? That guides testing strategies, contact tracing, recommendations for masks or distancing.
Makes sense.
How exactly is it transmitted? That informs hygiene advice, cleaning protocols, even vaccine development. Understanding who's most susceptible to severe disease helps prioritize who gets the vaccine first. Without a decent grasp of how a disease naturally behaves and spreads, our attempts to control it would be, well, like shooting in the dark, much less effective.
Wow. It really is becoming clear. This isn't just some academic concept. Understanding natural history has incredibly real, tangible consequences for how we handle health individually and for whole populations. You mentioned polio, HIV, heart disease, COVID earlier. Can we dive a bit deeper into maybe one or two of those? See this in action. Let's start with polio. That seems like a success story.
Polio is an excellent case study. Understanding its natural history was completely central to its near eradication. We learned it was primarily an enteric infection starting in the gut, spread mainly through fecal-oral transmission.
Okay, starts in the gut.
Crucially, we figured out that the vast majority of infections were asymptomatic or just caused mild flu-like symptoms. Most people never knew they had it.
But not everyone.
No. In a small percentage, maybe 1%, the virus could invade the central nervous system and cause irreversible paralysis. That was the devastating part. And understanding the timing of viremia when the virus was present in the bloodstream was also key.
How did that knowledge help with vaccines?
It directly informed both the Salk and Sabin vaccines. The Salk vaccine, the inactivated one given by injection, targeted that viremia stage to stop the virus before it could reach the nervous system. The live attenuated Sabin vaccine, the oral one, actually mimicked a natural gut infection to create really strong, long-lasting immunity right there at the entry point. Mass vaccination campaigns focusing on infants and young children in the stage of susceptibility were built entirely on this understanding, and they've been incredibly successful.
That's amazing. Just understanding those details, where it enters, how it spreads internally was the key. What about HIV/AIDS? That must have been a terrifying puzzle initially.
It was a profound challenge, yes. When HIV first emerged, it was deeply mysterious and frightening. Figuring out its natural history was a monumental scientific effort.
What were the key breakthroughs in understanding?
Well, understanding its incredibly long latent period, that extended subclinical stage where the virus just silently replicates inside the immune system, often for many, many years without causing obvious symptoms, that was huge.
So people can have it for years and not know.
For years. Also learning how it gradually destroyed specific immune cells, the CD4 plus T cells, and how that eventually led to AIDS. Acquired immunodeficiency syndrome characterized by severe opportunistic infections because the immune system was so weakened.
And how did that understanding change things?
It was utterly transformative. It led directly to the development of diagnostic tests to detect the virus early, even during that long latent period. That was crucial for prevention and treatment.
And the treatments themselves.
Yes. Understanding the viral life cycle allowed scientists to develop antiretroviral therapies, RT, that target different steps in how the virus replicates. These drugs suppress the virus, slow down the disease progression dramatically, and very importantly, it informs strategies to prevent mothers from transmitting the virus to their babies.
So it went from a death sentence to
largely a manageable chronic condition for those with access to treatment. A stunning turnaround, really, and it's a direct consequence of painstakingly deciphering its natural history.
It really shows the power of that deep scientific understanding. Now, you also mentioned that modern tools are giving us even better ways to study the natural history of disease today. Can you elaborate on that?
Absolutely. The fundamental concept hasn't changed, but our ability to investigate it, to see the details, is constantly getting better thanks to advances in science and tech.
What kind of tools are making the biggest difference?
Well, consider genomics.
Yeah.
By analyzing an individual's entire genetic code, or specific parts of it, we can get incredible insights into their personal stage of susceptibility for many diseases. We can spot genetic variations that might increase or decrease their risk.
Leading to more personalized prevention.
Potentially, yes. More targeted primary prevention. And for infectious diseases, sequencing the pathogen's genome helps us track how it's evolving, maybe becoming more transmissible or resistant to drugs. That changes its natural history, and we need to know that.
So genomics gives us a sharper view of the starting point, the susceptibility. What about detecting things in that silent subclinical stage?
That's where biomarkers are becoming incredibly powerful. Biomarkers are basically measurable indicators of some biological state or process. They can be found in blood, other fluids, tissues.
And they can signal disease early.
Yes, sometimes very early, long before symptoms appear. Think about new blood tests, sometimes called liquid biopsies, that can detect tiny fragments of tumor DNA circulating in the blood. That could potentially flag cancer extremely early, right in the subclinical phase.
That sounds revolutionary for early detection. Okay, and the last tool you mentioned was AI. How does artificial intelligence fit into understanding disease progression?
Right. Artificial intelligence, AI, and machine learning are really starting to make waves here. AI algorithms are brilliant at analyzing massive, complex data sets. Think electronic health records from millions of people, genomic data, medical images.
Spotting patterns humans might miss.
Exactly. They can identify subtle patterns, predict how a disease might progress in a specific individual with much greater accuracy than older methods. This helps us refine our understanding of the natural history, especially for really complex diseases. It might help spot new risk factors we didn't know about or predict who's likely to develop severe complications.
Allowing for more tailored interventions.
Precisely. More personalized, more timely interventions at every stage, guided by a deeper data-driven understanding of the natural history.
So these tools, genomics, biomarkers, AI, they're like super-powered magnifying glasses, letting us see the natural history with much greater detail and precision.
That's a great way to put it. They don't replace the fundamental concept, but they give us far sharper lenses and more powerful analytical tools to understand it and, crucially, to apply that knowledge more effectively.
Well, this has been incredibly illuminating. It's really quite something to realize that this seemingly straightforward idea, how disease unfolds on its own, is actually the foundation for so much of what we do in healthcare and public health.
It truly is. We've talked about the definition, those key stages: susceptibility, subclinical, clinical, and then disability or recovery. And we've seen again and again how understanding that progression lets us find the best spots to intervene.
Whether it's primary prevention, stopping it before it starts,
Right, or secondary prevention, catching it early in the subclinical phase.
or tertiary prevention, managing the impact once it's established.
Exactly. It guides all those efforts. Without that fundamental understanding, our attempts to protect and improve health would honestly be much less focused, much less effective. It would be guesswork, really.
So pretty much every health intervention we encounter has this concept somewhere in its background.
Ideally, yes. Every vaccine, every screening test, every treatment plan, every public health campaign should be informed by a solid appreciation of the natural history of the condition it's targeting. That's the goal of evidence-based practice.
And it's good to know our understanding isn't fixed. It keeps evolving with new science, new tech.
Absolutely. Our picture of the natural history of many diseases is constantly getting more detailed, more nuanced. Think about long COVID, for instance. We're still actively delineating that stage of the disease's natural history.
Right.
But the core principle holds true. To effectively fight disease and promote health, we first have to understand its intrinsic story, its natural course.
So for you, the listener, maybe the next time you hear about a new screening guideline or a vaccine recommendation or even advice about healthy living, take a moment. Think about it through this lens we've discussed today.
Yeah.
Consider the natural history of the disease it's trying to prevent or manage. Appreciate that this fundamental concept, often working unseen in the background, has a really profound influence on your health and the health of everyone around you. It's a truly fascinating and, I think, crucial piece of understanding for all of us.